Welcome. I am a member of the People CDC and a person with long COVID. And today I want to tell you about the direct action to raise money for long COVID research called Moonshot for Long COVID, and have a discussion about the patient experience with long COVID. I am not a medical professional, and this is not medical advice. This is just one person with long COVID talking about patient experiences. On Tuesday, November 14th, between 3 and 5 p.m. Eastern Time, there is a phone blitz planned and organized by people with long COVID to contact our representatives and raise awareness for the urgency for long COVID treatments and funding for research. It's called Moonshot for Long COVID, and you can find more information at longcovidmoonshot.com. Patients with long COVID across the world are in an urgent crisis, and we're going to go over some statistics and some experiences of the urgency and the crisis of living with long COVID.
Long COVID is very difficult to see. Like almost every aspect of this condition serves to hide its own reality from public view. This attitude of needing to live with COVID means that you also must live with ignoring the people who cannot move past it.
So that's Pulitzer Prize winner Ed Yong at The Atlantic, who spoke with PBS about long COVID. He is not a person with long COVID, but he is an ally, and his writing and his interviews accurately articulate the experience of living with long COVID. So first, we know that long COVID is real, and some patient experiences, even though there's an invisibility to living with long COVID, it is very real and it shows up in all aspects of our lives. So that is a photo on the left side of my own supplements that I take, and some medications. Very few of them are prescriptions, and they are constantly changing as I try things that work, adjust doses, try things synergistically, and it is a full-time job just taking all of my supplements. We also see some social media examples of real people with long COVID and their experiences and what it looks like in the day in the life of somebody with long COVID, including children. There's a lot of numbers and debate and questions out there on how many long haulers are there really, and it's difficult to say because we were in very early stages of research with this condition. The number that seems to be used most commonly is 65 million, but regardless of how many there are, it's a massive amount, and there's simply way too many. The number 65 million that's used frequently, just to concretize it, is equal to the entire population of France. So if everybody in France had long COVID and was sick and was not working, you would probably see that from outer space. 65 million is also about the same number of Gen Xers in the United States. So that's an entire generation who would be disabled. On the right side, there's a tweet from Dr. David Putrino from the Putrino Lab, who accurately and passionately states that even if it's, quote, only 5 to 10 people, that is an enormous number, and we should be screaming. Harry Bobby is a person with long COVID and a professional judo champion. And here he cites some statistics showing that 16 million working age Americans have long COVID, 2 to 4 million are out of work, and the annual cost of lost wages is 170 billion. There's other statistics that are being shared, and we're going to go through them, but regardless, we can all say that these numbers are dramatic. This slide we're looking at now was shared with us by Patient-Led Research Collaborative, and their research seems to be the most comprehensive and up-to-date of anything that I've seen. And we can examine who gets long COVID, despite what commonly is portrayed in the media of it being middle-aged white women. That does not seem to be the case. It seems to affect everybody across all demographic. And Patient-Led Collaborative has seen that there's a higher prevalence in Hispanic Latino people, transgender people, and women. 1/3 of people with long COVID did not have any pre-existing conditions. So that goes against the common refrain of only the at-risk or the quote vulnerable need to be concerned about COVID. Here we have from August 2020, an article in The Guardian by Hannah Davis, who is a member of Patient-Led Research Collaborative. And she describes her early experience on the onset of her long COVID. This resonated with me because it was very much like my own personal experience. A lot of the unusual and pervasive and debilitating experiences were very specific. For instance, she talks about reminding herself how buses worked and had to remember how delivery services work. And those cognitive impairments were not typical for her personality and her skills prior. And that can be very disorienting and a frightening experience. I think Hannah has since improved from those. I don't want to speak for her, but I can speak for myself and say mine have also improved. Other experiences that people have that I had, there's some balance and proprioception challenges, problems with short-term memory, anomic aphasia, and derealization, which is sometimes described as the sense of not being in your body, of things being very far away, of being behind a pane of glass, and just simply not being very present in your body or in the world. Patients are very vocal on social media for different reasons. And here there are three people with long COVID describing their realities.
Hi, my name is Hannah, and COVID took my life from me. I was 23 when I got sick in August of 2020, and I'm turning 27 this month. I was an athlete for 10 years, and I had straight A's all through high school. I graduated with honors, multiple scholarships, and I was years into school for my PsyD. I loved going on adventures, traveling, reading, painting, drawing. I even loved having a job. I also had a healthy immune system, and that was all until I got COVID. I've been diagnosed with epilepsy, and the back-to-back seizures have caused brain damage. It has caused dementia-type symptoms, spelling problems, mood changes, POTS, which has caused me to be hospitalized multiple times with concussions and injuries. I'm on IV infusions and medication for that. I have to use a wheelchair. I can no longer legally drive. Diabetes and autoimmune disease. Chronic and debilitating fatigue, vision deterioration. Had to have my thyroid removed, lost half my hair. I still have a hard time breathing and have low oxygen at points. Chronic pain, muscle aches, tooth decay. Increased mental health issues and ideations. I had to quit my job, withdraw from school, and I never see anyone but my family and doctors. I can no longer draw, travel, and I really struggle with reading, which is my favorite thing. My loved ones are terrified to leave me home alone, and I'm scared to even sleep at night because I'm afraid that I won't wake up. I spend my days alone in bed because life has to go on without me. This is the reality of it, and 1 in 5 infections cause long COVID. I promise you, you are not invincible.
So that's Hannah. I think she's very brave. And I think importantly, she says that people are not invincible despite the messages we are hearing about only the at-risk or only the vulnerable. Gemma, who we're going to see next, has a great sense of humor about living with long COVID, even when describing some of the more difficult days.
Comments I have heard since getting long COVID.
I got long COVID too, and it really didn't affect me that much. I felt fine. Sure, it's long COVID, because it could just be depression. Did you have the vaccine? I never had the vaccine, and I'm absolutely fine. You're far too young to be dealing with all this. Well, my grandma got COVID, and she went to hospital, and now she's feeling fit. She's absolutely fine. Eating that kind of food is not going to help your recovery. Just have to push through. Oh, you're smiling. You must be feeling better. You should focus on the positives. People have it so much worse than you. What do you mean that was too much effort? You did it yesterday. Oh, come on, it's not that difficult to do. It doesn't take up that much energy. It's all in the mind. Have you tried yoga? Have you tried a parasite cleanse? Have you tried this herb? Seriously, it will help, and I'll give you a 20% off discount. You're still not better. Oh, that's been hanging around, hasn't it?
And then Harry Bobby, we saw a tweet from him earlier. He's a professional judo athlete and he has improved with his long COVID. And here he describes some of the dissonance that can be experienced when trying to express the difficulty of long COVID to others.
I broke my ankle a little while back and the amount of sympathy I got for that was crazy. I had get well soon messages, the doctors were super supportive and everybody took care of you. The pain of breaking my ankle compared to the pain that you endure every day you have long COVID is inconsequential. Furthermore, a broken ankle will heal, but long COVID, you don't know when it's going to end. I would rather break every bone in my body than suffer from long COVID again. And yet the support and understanding that you get with this condition pales in comparison to breaking your ankle, for example. We need to do better and support those who are suffering, not ridicule them.
So I think these patients are very brave for making themselves visible. A common refrain when people experience any kind of health crisis or scary diagnosis is people try to encourage you by saying, at least it's not cancer. And that can feel very dismissive. And we know that cancer is actually hundreds of different individual diseases, and many of them are curable and have no symptoms. A recent study showed that living with long COVID can be similar to late-stage cancer, IBD, Parkinson's, kidney disease, and that it has a disproportionately life-changing impact on women in particular. So when you are really sick and you have to stop to take care of yourself or you're debilitated by illness, you are not seen in public, you're not seen by people. So they don't see everything that you deal with. And that is also a factor that contributes to the invisibility of long COVID. Here on the left, Diana has been in a really tough crash the last couple of months. She has very little energy, so she's staying off her phone as much as she can. I'm in there with her every day, just holding her hand. Some days she's in pain, some days not as much, but always tired and on the verge of crashing harder. So we are being very careful. And this is a reality for a lot of people of being in bed for days on end. And the energy you have, you might get up just to use the bathroom or to feed yourself. And you're really, many people with long COVID are bedbound. The next video we're going to see, a mother describes her child with long COVID. And I think it's important for us to hear that this mother is very brave.
He was tired all the time. He had headaches kind of all the time. But everyone was saying kids aren't affected. Best place for them is school. He was so ill that he could no longer sit up in bed. His eyes were bloodshot. His ears hurt. His chest hurt. I mean, he was ill. And that was my darkest moment. And he was 8. Obviously, he couldn't go to school. He couldn't leave his room. My son now uses a wheelchair when we leave the house. He hasn't been able to access education in any meaningful way for 1.5 years. He sometimes goes in for an hour. Sometimes he manages a couple of hours in a week. When he goes in for that 1 hour, it takes him a long time to get dressed. Giving him medication so that we can control his nausea when he gets into the car. So I'll wait outside for him, and he comes out and he's shattered. And then he'll have to completely and utterly rest for the next 2 days in order for his body to recover from the physical and mental impact of going to school for an hour.
I think this underlines the severe crisis and desperation that long COVID is, and that this is a multi-generational crisis, disaster, and not only that it crosses generations, but this is going to resonate for generations because of the ages of people that it impacts. So some more information from patient-led research collaborative is that it impacts children of all ages. They experience fatigue, post-exertional malaise, cognitive dysfunction, memory loss, headaches, orthostatic intolerance, sleep difficulty, and shortness of breath. They have also found liver injury in non-hospitalized children with long COVID, and that adolescents with moderate to severe long COVID also have features that are consistent with ME/CFS. It seems also from their data that children with ADHD, chronic urticaria, and allergic rhinitis might also be at higher risk of long COVID. So Charlie McCone has made himself very visible and is a person with long COVID and long COVID advocate. And also Heather Hogan is among the very first people with long COVID to talk about it on Twitter, which is where the phrase was coined. And patients experience a lot of gaslighting from medical professionals, general alienation from people in their lives, and quite frankly, antipathy, growing antipathy from our society.
I wasn't really familiar with the gaslighting until I met with my first neurologist, which was about 8 weeks after. And he looked at me and he was kind of just insinuating that maybe I'm having a tough time coping with the pandemic. And that was really surprising. I just turned 30 years old. I was biking 10 miles a day, had a very, back and forth to work, had a very, active social life. Today, I'm 33. I've spent my entire 30s housebound, severely disabled with this condition. The idea of a bike ride is a distant memory. I can't really read books. I used to listen to music for, 4 to 8 hours a day. I can only listen to music for about 10 to 20 minutes at a time. I can only watch TV for about 45 minutes at a time. And so it's the quality of life of this condition is truly unfathomably low.
People who have
I think it's important that some people without long COVID or who are watching this who don't have conditions or symptoms similar to those experienced by people with long COVID, from the outside, somebody like Charlie might seem perfectly fine, and he can speak and he can think straight. But what's important is the patient's own baseline. So unfortunately, a lot of the tests that patients are using or doctors are using with patients to evaluate their ability or their level of disability, they might be, quote, normal within normal range. But what's important is the patient's baseline and listening to the patient. And if Charlie is saying that this is not like him and that it is debilitating for him, and then that's really what's important. And I think medicine is getting closer to accounting for that. So what's going on with research? This is a crisis. It's been going on for some people for almost 4 years. So the government has to be doing something, right? Like we've heard there's this Recover project that's been in the works for a while. What's going on with that? Here, Representative Anna Eshoo, who is also the chairwoman of the Health Subcommittee, asks the acting director of the NRH, what's going on with the progress of Recover and all that money that was given?
In March of 2021, the Congress passed, the president signed into law billions and billions of dollars for all of the things that would protect the American people. The Congress appropriated $1 billion to NIH to study long COVID. I think the effort is called Recover. Where is that? How close are you to coming out with what's needed for those that have been waiting a long time? I want to know how close you are.
Well, we're within the next few months to launch the first
mission.
interventional trials.
Mm-hmm.
The reason it has taken the time it has is because we wanted to build a large enough cohort of patients so that we would actually get actionable answers.
So it took from 2019 to now to get the cohorts?
Indeed it has.
How many are participating in it?
I'd have to get back to you with the specific numbers. As the virus evolved, so too has long COVID.
Well, exactly. That's why I'm asking.
And that's why we need to continue to build a cohort that's representative of the disease so that the answers that we get with our interventional trials will have some actionable.
Um, Many patients, and clearly Anna Eshoo has been frustrated with the lack of substantive progress on the investment at the federal level in long COVID research.
In March,
So this is where the money for long COVID at the Recover study has gone to. A lot of it has gone to observational studies, which have value, but patients are desperately wanting answers that are concrete and treatment. So as somebody with long COVID, this is an example of the kind of observational study I was involved in, which is really an email study asking me about my symptoms in comparison to my infection. And for those of us who can't anchor our long COVID onset back to a confirmed infection, we're not contributing really great data to the data that is being captured.
Earlier this month, we brought you the story of long COVID patients and their concerns about the lack of clinical trials for potential treatments. Now, a Bay Area lawmaker is looking for answers from the federal agency in charge of long COVID research. The California Report's Keith Mizuguchi has more.
This month, Congresswoman Anna Eshoo sent a letter to the National Institutes of Health. She's asking the agency to give an update on the progress it's made on long COVID research.
I want to know how much of the $1.15 billion that we appropriated, how much has been spent. And I want a detailed explanation and dollar amount for each funded activity.
Eshoo says the NIH told Congress that clinical trials for long COVID patients would begin in the fall of 2022. But so far, the agency has not started a single trial.
This is not acceptable. I'm deeply, deeply disappointed.
Eshoo says the millions of Americans suffering from long COVID symptoms deserve a response and for their condition to be treated with the same urgency as acute COVID-19. She says thus far, she hasn't received a response from the NIH. For the California Report, I'm Keith Mizuguchi.
So that was, I believe, in August of 2023. So that is even the follow-up to months prior, directly asking Dr. Tabak, where did the money go? So where did the money go? A lot of it went towards trials that patients have already done on their own or in partnership with their own healthcare professionals.
Earlier this
So a spotlight on a few researchers who have been in the media and who do seem to be taking a very patient-inclusive, patient-led approach. Dr. David Putrino is very visible. He's at Mount Sinai in New York, and he has been involved in a study in partnership with Dr. Akiko Iwasaki that produced some biomarkers or some proto-biomarkers. And that's very exciting because at the very least, or the very first thing it accomplishes is that it proves that there is something biologically going on with long haulers. And this is not a psychosomatic or a hysterical response. And this quote from him, when I read this, I heard it in Liam Neeson's voice when he says, to the minimizers and psychologizers of long COVID, Lyme, ME, CFS, and other infection-associated complex chronic diseases, your days of gaslighting patients and denying biological illness are numbered. We have a new generation of scientific weapons to wield against the misinformation and abject cruelty you have used to harm these communities for so long, and we will not let this stand. And I was so excited to see that because just for someone to acknowledge the harm and the cruelty, in addition to just living with a debilitating disease, to me, he's a protector, and I'm grateful for that. He's partnered with Dr. Akiko Iwasaki, who is at Yale, and here we have some graphs that came out of that study. And long COVID with me or long COVID with ME on social media does a really great job of representing these important findings. Dr. Wes Ely is another researcher who has demonstrated a lot of compassion consistently for long haulers. I feel very bravely here in his tweet where he admits that he didn't always even believe that chronic fatigue syndrome and long COVID, or that chronic fatigue syndrome was real until the phenomenon of long COVID opened his eyes. He admits that in medical school, he was taught that it was simply mysterious, and he's committed to finding answers. In this article from May 2023, I believe this was in the Boston Globe. He has some facts and figures in here. He says that, oh my gosh, I do not have it here. I apologize, but based on the numbers, I'm sorry, yes, it is here. Every 7 days, 25,000 more people joined the 10 million in the US with long COVID. And I did the math on that. That comes to almost 2.5 long haulers every minute in the United States. The TLC Sessions is a podcast of two people with long COVID, and they have hosted and interviewed some of these researchers. And that's one that I recommend if you're interested in hearing directly from researchers with a patient-led approach. Some of the biases and challenges that we're facing in research, and research biases is a focus of Dr. Iwasaki's research. We're facing challenges in PCR testing and PCR accuracy. Many studies who are even accessible to patients, or whether they're simply not accessible because many patients do not have a positive PCR test to point back to associate with an infection. And that's for lots of reasons. There's social determinants of getting access to those tests. Some people fell ill before those tests were available, and PCR test accuracy is a real factor. I think Dr. Petrino pointed out that there was an overlapping the failure rate of PCR tests was in line with the number of people in his clinic who did not have a positive test. So those are all things. Those are all things at play. We know that antibody tests are really good at showing positive, but not really reliable when showing negative. There's delays of symptom onset. There's quite frankly a dearth of knowledge for long COVID and infection-associated chronic conditions, even though they are not a new phenomenon. And of course, the ongoing slogans about get back to normal, the pandemic is over, and people simply trusting that if there was a crisis going on, that they would have heard about it from their government. So the Recover study, in order for that money that has already been allocated to be the remaining to be maximized and used effectively, we need representatives with lived experience who are accountable to the patient community on the steering committee. We need more consideration of the impact that these publications are going to have on patient outcomes when publishing and communicating them. We need more clinical trials on the concerns that patients are prioritizing over maybe what researchers think is important. Data needs to be validated with external cohorts. And we need more communication within and outside of the Recover people on how to use and not use the JAMA paper. What patient-led is referring to here in the JAMA paper is the study that patient-led collaborative published in partnership with Dr. Eric Topol. That's the 12 points of long COVID, and it highlighted 12 symptoms that are consistently associated with long COVID, and it has been frequently misrepresented and reductive, as if that those are the only 12 symptoms that patients are experiencing, and that's simply not what the study found. And we know that that there have been over 200 individual symptoms documented associated with long COVID, and it is a whole body condition. So what is this going to cost us? The money, the $1.15 billion has already been allocated to recover. But what is this actually going to cost us, and why do we need this moonshot? So Lisa McCorkle, who is a member of Patient-Led Research Collaborative, and Dr. Michael Peluso, who is as well, and he is a researcher up at UCSF. He's also on some other long COVID advocacy and research organizations. They have quantified that this is going to cost the United States over $3 trillion in the next 5 years unless something is done. And that is why we are asking the government to invest at least $1 billion every year over the next 10 years to address the problem. And that this investment would absolutely have a return. Some other numbers here comparing the concern of infection-associated chronic conditions to the other medical conditions that are considered high priority. So similar actions and similar efforts were made before us in health activism. And what can health activism look like in the digital age, especially when motivated people are simply fatigued and bedbound or can't gather safely for a number of reasons? ACT UP certainly was not the only organization who was committed to health activism and responsible for change, but they're certainly they were among the most visible. So here I'm referencing the first article on what became known as AIDS in mainstream media from July 3rd. That was not the first time it was published. That was the first time it was published in mainstream media. So that was in 1981. And AZT, the first drug for HIV, was only available 8 years later. And I believe it was 15 years after this was first published that the triple cocktail, which was very effective for people with HIV, was available. This is a clip of Larry Kramer, who is one of the founders of both GMHC and ACT UP, in conversation with a younger Tony Fauci. And you could say they were frenemies. They became friends. They became very close friends over the years. And this is a very funny and typical example of the very outspoken and animated Larry Kramer.
Is an understanding that that's the perception of, yes, there is something that we're not doing that we can do that will really make the difference. In fact, there are things, certainly, that you can identify that you can do better. But many callers, and we hear this all the time, would say, gee, if only the government did this, we'd get the answer. It isn't as straightforward and simple as that. If it were, don't you think it would have been done?
Yes,
Elizabeth
I do.
City?
I do, and I'm going to break in right here and say, Tony, all of that is bureaucratic bullshit, and you ought to be ashamed of yourself. There are, I could sit and we could make a list of 8,000 things that haven't been done that should have been done. And this is the part of you that makes me so angry when you talk like a bureaucrat and not like the wonderful doctor I know you are. You know that if I came down and gave you $25 million, there are 25 different things that you would do that you're not doing now. And science is done that way, and there are 1,000 things that can be done to make all of this happen faster, and you know it, and that's the part of you that makes me so angry.
Well,
so I'm sorry there's no captions for that, but I can provide a transcript. And I want to emphasize that the changes that ACT UP made benefited everybody in terms of speeding up drug development. And if anybody has ever taken Paxlovid, I think it's fair to say that that goes back to the efforts of from ACT UP and TAG, which was an offshoot group of their treatment action group. So this is all of this to say, this is why people with long COVID have got together to plan a 2-hour phone blitz to demand the $1 billion needed in annual funding to tackle this very urgent crisis that we need from our government. I want to emphasize that the people who initiated this, of course, they're patients, but they have an expertise in data and numbers, and This number is not arbitrary. It's coming from somewhere. They have linked it back to, asking to support the Long COVID Support Act, the Treat Long COVID Act, and the Long COVID Recovery Now Act. The People CDC will be sharing information, including a phone script and ways to contact your representatives on this date to demand this attention.